Dear SIOP members, dear International Society of Ocular Oncology members, dear friends, colleagues, welcome to our webinar of the SIOP Disease-Specific Portal for Learning and Networking. The DiSPLeN is one of the Global Health Network educational series, and you are welcome to another great series, the sixth one of the series. Today, we will be presenting about strategies to improve retinoblastoma outcomes in low-resource settings. We have very distinguished guests and the SIOP leadership here. You will hear of the president of SIOP, Guillermo Chantada. You will hear of Vera Yarovaya, Jessie Berry, who may not be able because she is now operating a child with retinoblastoma. She is a very well-known, as you know, of ocular oncologist. And I, Rejin Kebudi, and Zehra Fadoo will be moderating. I am Rejin Kebudi, a professor of pediatric hematology oncology at the Istanbul University, and I am the current General Secretary of SIOP, and I'm very happy to be here with all of you. My dear colleague, Zehra Fadoo, is the chair of the pediatric oncology at the GHN University in Pakistan, and she is a very experienced senior pediatric hematologist oncologist. Welcome, Zehra. And before we go on with the presentations, we want to give you a little background of the DiSPLeN series. As you know, SIOP, the International Society of Pediatric Oncology, is the only global pediatric oncology society, and we are trying to improve quality of care and also survival in all the world for all children with cancer. And this needs also education. And within our SIOP, within our society, we have a lot of networks, committees, working groups, all working a lot for this aim, for our vision and mission, which is cure for more and care for all. And for the education, the Global Health Network has organized these disease-specific portal for learning and networking. SIOP Global Health Network's initiative to provide additional learning avenues to SIOP members, learning forum on various aspects of care directed at common curable cancers. We are conducting learning sessions focusing on care-based discussions, as you will hear today. You will first hear of a case, then diagnose and referral pathways, access to care, and advanced diagnostics and therapeutic modalities. The invited faculty are SIOP members with enormous experience and expertise. They are the disease experts. This plan enhances SIOP membership engagement and contribute to the professional nurturing of SIOP Global Health Network members. This is the pilot phase. The pilot phase was from December 2024 to May 2025, and we had the DiSPLeN group chaired by the co-chair of the Global Health Network, Mohammed Sagir Khan. We thank Dr. Sagir a lot for this initiative. It was planned for 6 webinars, and today is the 6th one. We have globalized the already existing smaller and regional group on disease-specific learning. Display team coordinated the education day sessions along with the local SIOP Asia organizers during the SIOP Asia 2025 Congress that was held in Riyadh, Saudi Arabia last April. The ultimate goals are the expansion of the project to non-English languages to engage global representation, connect with other projects within SIOP and SIOP continental branches, and actively interact with key global stakeholders and childhood cancer initiatives. There has been 5, before this one, there have been 5 webinars, which are all on the YouTube. The recordings are all on the YouTube and you can reach them. The first one was on low-grade glioma, and we had very distinguished speakers all the time, and Eric Buffet, past SIOP president and a very experienced neuro-oncologist, was with us in the first webinar. The second was on the medulloblastoma, should molecular subgrouping change our management? And we had very distinguished friends and experts, and Mariam Fouladi from USA was the expert speaker. And in both, Noreen has also moderated. Noreen, our friend Mustache from Pakistan, And also the third one was an update on the management of advanced pediatric Hodgkin lymphoma. We had very distinguished guests from UK and UK, from Netherlands, and there was a lot of discussions, very good question answer sessions. The fourth one was on Wilms tumor, and in this one also was very well attended. Rejin Israel's Gabriella Villanueva moderated, and there was guest presentations, and Filippo from Italy was our guest speaker. And the fifth one was on ALL, acute lymphoblastic leukemia, strategies to reduce relapse risk in low resource settings. And this was moderated by Helena from Serbia and Kirill from Russia. And our invited speakers were Cesar Nunes from USA and Martin Schrappe from Germany. And really, this has the feedback has been great. And today we will have another great session led by our very experienced experts, and especially we will welcome them again. But I want to also welcome once more and thank our president, Guillermo Chantada, for being here as the expert speaker. We are very much honored to have him here also. And in fact, I will also, as I said, in the SIOP Asia Congress in Riyadh, in Saudi Arabia, the educational day was organized by the DiSPLeN team, and there were very important messages from Burkitt lymphoma, Hodgkin lymphoma, ALL, and you can see a picture of the participants from SIOP and the expert speakers, which was the feedback was really great. And I would like also to tell you about some housekeeping instructions. You can click on question at any time. You can write your questions. There is no voice option for audience, so please write your questions and we will try to answer them live at the end of the session, or sometimes writing to you, back to you. Text answer will come from the expert if possible. There will be a dedicated question answer time after the presentation. And at the end, there is also a certificate of attendance for the ones that want a certificate. To do that, a survey will be sent through the SIOP website portal, and you can get a certificate of attendance as well. So with this, I will stop sharing, and I really welcome all our my co-moderators, Zehra, Fadoo, all our speakers, Sara, who will present the case, Guillermo, Chantada, our SIOP president, who will be the expert speaker, and Vera, also the Vera Yarovaya, ocular oncologist, will be our guest speaker. Welcome to Guillermo, Vera, and Sara. And Zehra, I'll give the word to you now so that you can present Sara and she can present her case. Thank you very much in advance for all the speakers and the participants. And also I want to thank Dr. Sagir Khan for leading this initiative, and the DiSPLeN team that has worked a lot for this DiSPLeN program. Thank you so much.
Thank you so much, Dr. Kebudi. And thank you for organizing this very interesting seminars and very informative. So the session will start with a case presentation, and I have the pleasure of introducing Dr. Sara Azeem. Dr. Sara Azeem is a pediatric hematology oncology second year and final year fellow at the Indus Children Cancer Hospital, Karachi, Pakistan. And I would like Dr. Azeem, you can now start your presentation. So we start with the case, then we can continue with our seminar.
Is my screen visible to all?
Yes.
Am I audible to all?
Yes. Yes, please go ahead.
Thank you so much, Dr. Zehra, for giving me a nice introduction. So I'm going to present a case of two brothers of the same family. So the first one, the elder one, is a 20-month-old male child weighing 9 kg, came in the ER of the Indus Hospital with complaint of the bilateral leukopodia and a decreased vision since birth. And the younger one is a 8-month-old male child, weighed 8.5 kg, Same day, he came with the elder brother with same complaint, the left eye leukoporia and the decreased vision for 5 to 6 months. So they both are the same family with the non-cancerous issue. In the family, there is no any history of the cancer. So on examination of the 20-month-old male child, there is no any anemia, no cervical lymphadenopathy. Eye examination showing the left eye white opacity and the right eye showing the buphthalamic with the photophobia. Another systemic examination is unremarkable. The younger one examination showing no anemia, no cervical adenopathy, and the eye examination showing the whitish opacity in the left eye and the fellow eye is normal, and other systemic examination is also unremarkable. So we did the initial workup in the form of the examination under anesthesia of both the child. The left, in the younger, in the elder one, which is the 20-month-old, which showing the left eye is a group E and the right eye is group D. And the younger one child whose age is 8 months, he's also showing the right eye group B and the left eye is group E. So we did the MRI brain and orbit with contrast. These are the images of the elder one. In the T1 image, T1 axial plane image is showing the hyper intense signal or the abnormal signal showing both the posterior chamber of the eye as well as is also present in it is also more marked present in the contrast images. It's showing the hyper intense in the left one as well as in the right one, and the measurement of the right one is about 1.5 into 0.5 centimeter, and the left is the 1.2 into 1 centimeter. And also there is a bulky appearance of the right optic here. It's showing, but the images are not so good. But we can see this. There is a right optic nerve appears the bulky, and the left one is normal. So in this sagittal view, the brain images in the pineal gland seems to be the normal, and there is no any brain edema or anything present in the brain. And this is the axial view, which is also showing the hyperintense signal in both the eyes. So this is the MRI brain and the orbit with the contrast of the 8-month-old child. And in this contrast images, the T1 plane is showing in this T1 the abnormal signaling present in the left one, and also which is more marked in the contrast as well. And the optic nerve in this seems to be the normal, and the sagittal view also the pineal gland and suprasellar region all are seems to be normal, and brain looks okay. So we did the staging workup in the form of the CSF cytology and the bilateral bone marrow of both the childs. Both seems there is no any malignant cell infiltration, and this is the localized bilateral retinoblastoma. So we start with the chemotherapy along with the counseling with the upfront nucleation. By the time we are starting with the chemotherapy in the form of the CEB. Thank you.
Thank you,
Over to
dear
Dr.
Sara.
Zehra.
Yeah, Dr. Zehra, we thank Sara for the case presentation. If there are any burning questions, we can take them. Otherwise, maybe we can go on with the presentations. There's one question here. Do you do bone marrow and lumbar puncture for the CSF cytology to all patients with retinoblastoma? In fact, I think this will be answered in Dr. Chantada's presentation. Will you cover that, Dr. Chantada, or shall we answer it now?
I prefer to answer now.
Yes, please.
Yes, that's a good question. We don't do routinely, it depends on the center, but most centers do not do routinely bone marrow and CSF. For the first case, the case that had 20 months of age, since there is evidence of optic nerve invasion, I think we would also do at least a lumbar puncture. For the second case, the 8-month-old baby with intraocular disease, most centers will not do because the yield is very low. But it also depends on where you work, because in Europe, the chances of having extraocular disease is so low that we don't do it. But in Pakistan is another story, because you have more cases with extraocular disease, so you're probably going to pick up more cases than we in Europe. So there is not yes or no answer. It also depends on where you live. But if you decide to do it, the bone marrow examination should be bilateral punctures and biopsy, because the infiltration is patchy. So if you do just one aspiration, you will probably not find what you're looking for.
So there is another question from Hussein Itrarat. Bone marrow explorations for intraorbital forms in our setting. Maybe is there, Dr. Zehra Fadoo, would you like to tell what is in your normal protocol? Who do you do bone marrow aspiration, biopsy, and who do you do lumbar puncture and CSF cytology?
Oh, thank you. So just a follow up on that, I think if it's we had a standardized protocol that we made for the Pakistan Society of Pediatric Oncology, and I think in that standardized for now, we put for advanced and bilateral retinoblastomas, we did put in bone marrow, aspirate and refine. And again, like Dr. Chantada said, it has to be a bilateral bone marrow aspirate and refine with the CSF. So I think that's kind of a standardization that we have started off with. And I think there's been, I think Dr. Halima presented the data also in the SIOP Asia of all the participants and, that we have. So I think this is what we started off with, and eventually let's see what the results show. And maybe like Dr. Chantada said, that if the yield is low, then maybe we can stop doing that. But for now, all advanced and bilateral retinoblastoma and advanced disease, our protocol is recommending that we do both bilateral bone marrow aspirate refine and CSF.
I think this is a question that we will also discuss at the end, because Alia also was saying that if, shall we do bone marrow and CSF analysis only in extraocular? And if we are to do it in intraocular, in which ones? For example, usually we ask the ophthalmologist, sometimes they say when we look at the eye with general anesthesia and we cannot see the optic nerve too much, then they say, I'm really nervous. Why don't you do a CSF cytology also, like in a group E, that is not extraocular in the MRI, but they cannot see it too much. But otherwise, what I think Dr. Chantada says, in the intraoculars that are really intraocular, we do not need to do it. But in extraocular, we always need to do it, the general concept. Yeah, I think we will discuss this more. And another question before we go to the presentations. Why didn't Shabana is asking, why wasn't in the an upfront enucleation done in group E, case 1? Sara or Zehra, do you want to answer it, or maybe we after we hear all the presentations we can
Sara,
talk
you have
when we do enucleation?
Actually, ma'am, here in the Pakistan, there is a low socioeconomic country, so patient understanding is very low. So if we are offering them the upfront enucleation, they are abandoned. So that's why we are starting with the chemotherapy. Meanwhile, we counsel the patient, and after the 2-3 cycles, we will offer again the enucleation.
Okay. And in the ones that are enucleated, because Shabana is asking, what about if anterior segment involvement or if not enucleated? if there is anterior segment involvement, would you recommend a lumbar puncture and a bone marrow aspiration? What do you think, Dr. Chantada?
Depending on the case, if we have just that and the optic nerve is clear, we don't do it either, because now you can even save an eye with anterior chamber invasion, so it's not considered anymore a high-risk feature for metastatic disease when it's isolated. Of course, if we have optic nerve invasion like you had in this case, and I will also agree with the management, because if you go ahead with primary enucleation, if you have MRI evidence of post-laminar optic nerve disease and you have ophthalmia, you have two risks. One risk is that you will puncture the eye because these eyes are very swollen. They can rupture. Even in experienced hands, they can rupture and then it's seated in the orbit. So that's a disastrous consequence because you need then to irradiate. And also because the eye is so swollen, probably Vera can elaborate on this more. The ophthalmologist cannot access the whole length of the optic nerve. So sometimes they get back with a short optic nerve stump, and then there is tumor at the resection margin. And that is also a problem because then you have to irradiate, you left tumor behind. So it's a good idea to start with that, with neoadjuvant chemotherapy. In these cases, when one might discuss if the regimen should be of higher intensity, depending on the setting where you are. You may use a higher intensity regimen that will probably go a little bit faster in terms of chemo reduction. But I totally agree in that case that I will start with chemotherapy, even in the scenario of no abandonment risk.
Well, I believe we'll have a lot of question answers and comments at the end. It is good to have those. And so I think we can go on with the presentations and have the questions, answers, and the other comments, and we can discuss more and more. Now, when we will continue with the presentations, and our first presenter is our very distinguished guest, Guillermo Chantada, who needs no introduction, but I'll still introduce him. First of all, I'm so happy to introduce him as I'm so happy to say that he is my friend for more than 30 years, but he's our SIOP president. We are very proud to have him as our president. And other than that, as you know, his affiliation at the moment, he is the head of the outreach program in the Pediatric Cancer Center Barcelona in the Hospital San Juan de Dios. And also he's the scientific director of the Hematology Oncology Service in the hospital in Montevideo in Uruguay. He has his university education in Argentina and his pediatric hematology oncologist fellowship, and he worked in the hospital in Argentina for 31 years. And also, we know that he is an expert in retinoblastoma. He has a lot of translational studies and clinical studies in retinoblastoma. And also, he was the president of the SIOP Latin America, the SLAUP. And also, he leads the Latin American treatment protocol at the GALOP, the Grupo de América Latino de Oncología Pediatría, where he is the member of the board and for the protocol in retinoblastoma also. He serves as the coordinator of the European Retinoblastoma Group. And in fact, he has also tried to collaborate with all people globally that sees retinoblastoma, that are reference centers for retinoblastoma, to put us in many international groups in retinoblastoma. And for that, I thank him a lot, really. He has done that for our groups and other groups. So he has tried to collaborate. That's something that he does so well, as our president now also. This is very important that we collaborate as in all continents, in all the world, so that we can have better results in all the world. And he has a lot of work also in lymphoma, in a vaccine in neuroblastoma, retinoblastoma, histiocytosis, among all others. And so I have the pleasure of introducing him and giving the floor to Dr. Guillermo Chantada. Welcome, and the floor is yours.
Thank you very much, Rejin, for this kind introduction, and I celebrate our friendship for more than 30 years now. Yeah, it is very nice. Dan, thanks for your words. And talking about collaboration, let me start with this picture. We are today also celebrating that the SIOP, the International Society of Pediatric Oncology, and the ISOO, the International Society of Ocular Oncology, this picture was taken last Friday in Los Angeles, where I visited Jessie Berry at her hospital to give a lecture, and we took the opportunity to sign the agreement. We are both presidents in our societies. This is the start of a great partnership. I think, as you know, retinoblastoma is one of the 6 index tumors for WHO. We have to work together, pediatric oncologists, ophthalmologists. So it is so good that we could celebrate this partnership. Unfortunately, Jessie had an urgency with a patient and cannot be here with us today, but she was very instrumental, she and Dan Gombos, the previous president, to make this happen. So let me celebrate this great time with you, and looking forward to doing more with the ISOO. I'm a member of both societies, of course. So, well, we are on track now because we have a very interesting case. So let me start with this sketch. That sketch, I always said that, I have to confess, was done what was done by one of my fellows a long time ago, because he didn't understand how to work up a child with retinoblastoma. So he said it has to be something that is standard, that we could use without being you, that someone can do it without knowing about retinoblastoma. So this is what he came up, and I think I'm still using it for more than 15 years. So the first question, as in the first case, right? Our first question is does this child has overt extraocular disease? What do we mean with overt extraocular disease? This is tumor that is seen by imaging or clinically. In this case, we can say yes. But sometimes the optic nerve can be tricky in low resolution MRIs, but in this case, it looked like there was enlargement of the optic nerve. So when we say yes, we have to do extensive workup for metastasis, as we mentioned before. But if we say no, if the disease is intraocular, the next question, we don't need to do extensive workup for metastasis, but the next question is, can we save the eye? And that, again, is not easy, like a yes or no answer, because that really depends on where you work, depending on what are the possibilities of eye salvages that you have. Sometimes you work in a place where you have everything from intraarterial chemotherapy, intravitreal chemotherapy, everything. And sometimes you work in an institution that can only offer systemic chemotherapy, or you cannot offer eye salvage. But it will also depend if the child has unilateral or bilateral disease, as we are going to see later. So this is not a yes or no question, but this question is important because it is not the pediatric oncologist who answers this question. This question is answered by a multidisciplinary team, but mostly by the ophthalmologist. The ophthalmologists that work in our team will be the ones that know if this eye can be salvaged. So if we decide that the eye is not salvageable, then we go to nucleation. We're going to say some words later. Then it's important to do a pathological examination. And then there are pathology risk factors that we agree most of them. Sometimes we don't agree in a couple, like massive choroidal invasion. For some, it is not necessary to give chemotherapy. For others, yes. But there is usually a protocol, an institutional protocol that you should follow. And then again, if there is microscopical residual disease or pathology risk factors, you have to do extensive workup for metastasis. And also something we have not mentioned before, if you find cells in the CSF, it would be great if you could do your best to confirm that these are retinoblastoma cells. That because cytology alone is not specific enough. You can get confused with a child that has a viral disease and meningitis or other things that could cause CSF pleocytosis. And because the treatment is so different, you need to confirm that. If you have anti-GD2 antibodies, you can do that. If you have CRX by molecular biology, by PCR, you can do that. But if you don't have any of that, probably you have flow cytometry. And if you have flow cytometry, at least you can say that these are non-hematopoietic cells. That's enough. That then you can say, well, this is non-hematopoietic, they are retinoblastoma. But what do we do if we say, okay, we can preserve the eye? And that will be the most of my talk. So you face very critical facts when you manage children with retinoblastoma. And this is very important because when you fight for life, this is here. When you fight for life here or here, because the child is in risk of dying of retinoblastoma, you need to treat the whole body, because especially the CNS, because retinoblastoma can metastasize and the child will die of metastatic disease if you don't treat the whole body. But if you fight for vision, you need to treat only the eye. We now know that if we select the patients properly, there is no risk of ocular metastatic disease, so you can give ocular only treatment for these children. But coming back to the cases, the first case, the child with 20-month-old, it's fighting for life. The second child, the 8-month-old child, is fighting for vision. So there are two completely different scenarios. So this is the very, very important. I'm very thankful that you put these two cases to make this comparison. Why? Because also you need to consider that children with germline mutation of the RB1 gene may not only die for retinoblastoma, but they may die for secondary malignancies in the future. And that is because their genetic predisposition, but that is also influenced by the treatment we give, especially radiotherapy and systemic chemotherapy. So, more questions to our puzzle. Does the child have unilateral or bilateral disease? Mostly in lower middle income countries, we don't have the results of the RB1 gene mutation at the time of diagnosis. So we usually tend to assume that if there is no family history, unilateral cases are non-hereditary, like 90% of the cases, but please consider that 10% can be hereditable. Because that has a lot of implication for how you decide the treatment. Because if the child has unilateral disease and you're quite sure that there is no hereditary disease, there is no risk of secondary malignancies, there is no risk for trilateral retinoblastoma, there is no major visual advantage compared to enucleation if the eye is preserved. So, except you have a family that won't accept enucleation and you have a unilateral group D or EI, go to enucleation in lower middle income countries, especially if you don't have intraarterial chemotherapy, because you will cure the child very soon. You will not put the life in danger. You will spend less resources. And the results are influenced by ocular group like all the time. But if suppose you decide to preserve the eye, again, I'm really a fan of enucleation in unilateral disease. When I worked in Argentina for many years, it took us 30 years to reach 99% survival rate in intraocular unilateral retinoblastoma. And that is because we enucleate the children. We really, like an exception that you could save a unilateral group D or EI if there is no risk of the family abandoning treatment. So when and how you preserve an eye with unilateral retinoblastoma? Surely, if it is a group B or C, they will do very well. Some group D, especially if the macula is not involved and there is some visual potential, and I will try only if you have intraarterial chemotherapy available, because the results of the treatment of group D with systemic chemotherapy and the toxic mortality that we have in low and middle income countries are not better than enucleation. But if you decide to treat and you have intraarterial chemotherapy, this is the preferred therapy. Because as you see in this Kaplan-Meier curve, this is the first study that was published by Francis Munier comparing intraarterial versus systemic chemotherapy for the salvage of unilateral cases in Switzerland. You see that the difference is absolutely significant. So we favor that has been reproduced by all groups, and even in a randomized study, like I will show you later. But please consider that, go back to the first case, the case with the 20-month-old. This case should not be considered for eye salvage. You give pre-enucleation chemotherapy, not conservative treatment. That is not the same, because there are many series that put all the patients together, and then you get confused, because this is a completely different situation. And I mentioned a randomized trial that was published from China a couple of years ago. Great paper, Lancet Child and Adolescent Health. I made also an editorial of that paper. And they randomized unilateral retinoblastoma patient, intraarterial versus systemic, and you see the difference. It was progression-free survival 53 versus 27. This is before the era of intravitreal chemotherapy. So, but that is roughly what everybody gets, no more than 30% of preservation rate with systemic chemotherapy. Again, and please consider that there could be mortality, treatment-related mortality. So I mentioned that if we decide to keep the eye, you don't need to give systemic treatment, because again, the risk of occult metastatic disease is now known that it is not a big risk with intraarterial chemotherapy and intravitreal chemotherapy. You are not facing any risk of the child. And also because we know now that there is no influence of systemic chemotherapy in preventing trilateral disease in cases with germline mutations. So if you decide to save the eye and you have access to intraarterial chemotherapy or intravitreal chemotherapy, it's the treatment of choice. So these are the options. This for intraarterial chemotherapy, an interventional radiologist, neurosurgeon, depending on the country, on the setting, they will make the super selective catheterization of the ophthalmic artery. They will infuse chemotherapy, usually melphalan alone or with topotecan, as a first passage to the eye. So the systemic dose will be very low, but the ocular dose will be extremely high. I always say, with the perspective as a pediatric oncologist, it's like a mega dose, like you are doing the mega dose for bone marrow transplantation. This is what you do for intraarterial chemotherapy for retinoblastoma. And again, there was the concern that these children could have higher risk of metastatic disease. But this, in a great study that Paula Shajkevich in Argentina did when we were together a few years ago, she did in an animal model, tested how much chemotherapy gets into the optic nerve compared intraarterial versus systemic chemotherapy. And why? Because the optic nerve is the site of primary dissemination of retinoblastoma. So most children that would die of disseminated retinoblastoma would be because the tumor disseminated through the optic nerve. So you see here the concentrations of the drugs in the optic nerve after intraarterial chemotherapy compared to systemic chemotherapy. The difference are in the thousands. So there are thousands times more chemotherapy when you give to the optic nerve after intraarterial chemotherapy compared to systemic. So it is highly likely that the optic nerve dissemination would be very well treated with intraarterial chemotherapy. In fact, the first case that had optic nerve invasion, some groups will now treat with intraarterial chemotherapy, like my own in Barcelona. But intravitreal chemotherapy, as you see here, is also a very important treatment component, as I'm sure that Vera will also mention. So that really changed the picture. We started using melphalan because that was very active for intraarterial, but then we realized that it was very toxic, and it took some years until we learned how to use topotecan and how to get with the right dose. So right now, topotecan has replaced melphalan for intravitreal chemotherapy. So there are many advantages for eye-directed therapies, better results for eye conservation that is non-disputable anymore. No alopecia, of course. Sometimes you have some eyebrows alopecia, but no more than that. There is lower impact on quality of life, no febrile neutropenia, no transfusion, no catheters, less infections, and very importantly, less impact in inducing secondary malignancies. There are also disadvantages because at that time that you're infusing melphalan into the artery, the ophthalmic artery, the eye, instead of receiving blood, it is receiving a poison, which is a nitrogen mustard. So we saw some vascular effects. We even saw blindness, very uncommonly, and depending also on the skills of the treating group. But there are more ocular side effects. This is also undisputable. But it is very expensive treatment. You need a highly qualified and equipped group, and a group that does many, because there's a learning curve here. So even there is a COG study that you can read that they found that it was not feasible in the US in small centers because they have a learning curve, as in every surgical procedure. So you need a team that is experienced to do it. But again, an ode to enucleation, it's a life-saving procedure. It's the adequate treatment for most unilateral cases, especially in our setting in low and middle income countries. Be sure you do your best. Be sure that you put that the most skilled ophthalmologist is doing it. That for the ophthalmologists, they need to be there. They need to be the ones that do it every time. Take time, as it was mentioned before. Sometimes it's very hard for the families to come with a child that looks well and they say, well, we are going to take the eye out. So it's very hard. You need to involve yourself in the discussion, involve your psychosocial team, take time, be prepared for that, and adapt to your resources, of course. Sometimes you will read that in New York, they save 90% of the eyes. But if you don't have intraarterial chemotherapy, you better save 90% of the lives. That is a great job that you will do. And also, as we saw in the previous case, be flexible. Sometimes you need more time. Sometimes families don't accept immediately enucleation. Sometimes they need a course of chemotherapy, maybe a couple of courses. That is really good medicine, and that you buy time, and then you will reduce the abandonment rate. But be sure you nucleate the eyes timely. If you nucleate here, probably the risk of occult dissemination is very low. If you are here, it is becoming higher. But you are here, the risk of occult dissemination is much higher, like in the first case. So it's a good idea to give neoadjuvant chemotherapy before the nucleations for the reasons we said before. Incredibly, Latin Americans are not famous for being in agreement with many things, especially in terms of football. But it seems on retinoblastoma, we were quite in agreement. And a few years ago, we published this agreement on how to approach conservative treatment of retinoblastoma. It was published in PVC. I welcome you to read that paper. If you don't have access, please let me know and we can share that with you. And the most controversial thing is how to approach bilateral retinoblastoma. This is really complicated because you need to, like in the previous case, you need to consider both eyes, the age of the child, and many other things, and of course, the availability of treatments that you could have. So this can be just a whole lecture, but if you have less advanced disease in both eyes, you can, even if you have intraarterial chemotherapy, except there is macular involvement, systemic chemotherapy and intraarterial chemotherapy have the same results. And maybe you save intraarterial chemotherapy for the ones that relapse, you're going to do a good job. 90% of the cases you will save the eye without radiotherapy, of course. Radiotherapy is not given anymore for ocular preservation. But most of the times, in low and middle income countries, you will see the scenario that was shown in the previous case, either DDIs or DEIs. So if there is DDIs, like the second case, if you have intraarterial chemotherapy, the treatment of choice is intraarterial chemotherapy plus intravitreal chemotherapy, you will get to 80% preservation rate. And that will mean avoidance of blindness in these kids, because about 30% of them with systemic chemotherapy, they will be rendered blind. So if you have like in upper middle income countries or high income countries, the most common situation is that you have one group DI and the other is A and C. Here depends. If you have intraarterial chemotherapy, we use intraarterial chemotherapy. But the other option could be, if you don't have intraarterial chemotherapy, to enucleate the eye, as one of our colleagues suggested, that you enucleate the DI and then you treat with systemic chemotherapy the less advanced size, and then you can have a good possibility of vision. So, but you can tell me, well, okay, I don't have it. This great lecture, very nice, thank you, but we don't have intraarterial chemotherapy. So what you could do, you enucleate your children with groups D and EIs always. Use systemic chemoreductions with carbon vincristine. We don't use etoposide anymore. If you don't know why, come to the next lecture that we are going to have 2 p.m. Barcelona time. We will talk about secondary leukemias in retinoblastoma, so you will forget about etoposide in these children, plus intravitreal therapy that could give you better results. Again, don't forget to save lives. Enucleate when needed. Sometimes enucleation is bilateral, but if you are going to save a life. And especially if you don't have intraarterial, please be mindful of the second eye. So if you enucleate one eye and then you have the only remaining eye, and you take a lot of time to enucleate because it's the only seeing eye. It's human. You try to preserve this eye. The family wants to preserve the eye. The child is usually old enough. But sometimes you lose this state of metastatic rays, and these children have a higher risk of extraocular relapse. And don't let a child die just to preserve one eye, usually with poor vision. So please read this paper that we published from the European Retinoblastoma Group. So let me conclude now. The focal ocular therapies are increasing use. We should decide knowing not just the disease, but just also the local situation. And in cases where occult dissemination is unlikely, intraarterial chemotherapy plus intravitreal chemotherapy gives better results, acts faster, and it is less toxic. But again, patient selection is really critical, just not to put a life in danger to try to preserve one eye. So thank you very much. And thanks again for the opportunity, and congratulations, Sagir, for this really wonderful series of talks.
So thank you a lot, Dr. Guillermo Chantada. You have answered many questions, but at the end, I think it will be nice to go some over some and emphasize some other what to do in the diagnostic, when to do the CSF, when to do the bone marrow, and when to do enucleation, and when to do the pre-systemic chemotherapy, and if available, the intraarterial chemotherapy for take-home messages. And now I would give the floor to Zehra to introduce our next speaker, the ocular oncologist, Vera Yarovaya. Thank you for coming, dear Vera. Zehra, can you just introduce her?
Yes. Thank you so much. Thank you, Dr. Chantada, for a very informative session. And I think there are a lot of questions that will come up, and we can do the question answers after this talk. So it's my honor to introduce Dr. Vera Yarovaya. And she is not only a medical doctor, but she's also a PhD. So it's a double D there. She's a member of the International Society of Ocular Oncology and European Ophthalmologic Oncology Group. She's affiliated with Ocular Oncology Department at SIOP GHN Eye Microsurgery Federal Institute in Moscow, Russia. Her interest and professional interest and research are intraocular tumors, retinoblastoma, melanoma prognostication, genetic surgery, brachytherapy, laser, radiosurgery, and intraocular surgery. So off to you, Dr. Vera. Looking forward to your talk.
Dear friends, nice to meet you in this meeting. So I'd like to speak on the topic of local treatment of retinoblastoma. and we'll start. So it is known that modern treatment of retinoblastoma is a two-step approach, and it includes chemo reduction with the use of local and systemic chemotherapy, and if necessary, consolidation of a residual tumor tissue by focal methods. So chemotherapy remains to be the first line of the retinoblastoma treatment. However, focal treatment is required still because of the resistance or relapse of retinoblastoma or failure of further chemotherapy. So we usually go to the focal treatment modalities. So in our center, there were about 300 patients with retinoblastoma, 300 and about 60 eyes treated. And 78% of patients in our study underwent systemic or combined chemotherapy. And it was also prior to focal treatment. And only in 90 patients, there was only local treatment, only local therapy without chemotherapy used, and also in 29 patients, the intraarterial and intravitreal chemotherapy was used without any treatment modalities. So in very past, we used external beam radiotherapy, and it was used in 7 patients. Now we don't use this modality, and I'll speak about it a little bit later. So, it's real challenging cases when you treat the single eye, and in our study, there were 59 patients that were treated with different modalities. So, patient distribution according to the BC classification of retinoblastoma is presented on the slide. Will not stay here, but you can see also that the majority of patients were presented with group B, D, C, and also E retinoblastoma. So the first treatment modality was laser thermotherapy, and it was performed by transpupillar route using laser system connected with binocular ophthalmoscope, and by transscleral route using the transscleral probe. So I will not stop on the parameters here, but we usually use laser thermotherapy in the scanning mode, and the exposure varied from 3 to 15 seconds, and the laser spot can be different from 1 millimeter to 1 millimeter 0.2. So for brachytherapy, we use beta ray plaques with ruthenium or strontium, and the median apical dose for ruthenium plaques was 89 gray, and for strontium 152 gray. So cryotherapy was performed by a double or triple freeze thaw technique for 60 seconds with the carbon dioxide. So the half of patients was treated by one focal method, more often by thermotherapy. 34% of patients by two methods, and 17% of patients by all of focal therapies. So complete tumor regression by first or fourth regression patterns was achieved in 76% of patients. Partial tumor regression was achieved in 15% of patients, and also we've seen tumor progression in 25 eyes and tumor recurrence in 2% of patients. So tumor control varied also for eyes with different tumor stage, and was significantly lower for eyes with group D. And the most frequent complication of local treatment were non-proliferative retinopathy, optic neuropathy, and also hemorrhage, vitreous hemorrhage. Ocular complications also varied depending on the tumor stage, and most often complications occurred in group D patients, which is just can be seen in every case. So the high rate of complication was admitted in eyes treated with bracket therapy and in eyes treated with a combination of different focal methods. So as a result, we have 93% of eyes saved, and there were 7% of eyes enucleated because of the tumor progression, either anterior chamber seeding or the lack of observing the retina because of the vitreous hemorrhage. So the lowest eye preservation rate was also observed in patients with retinoblastoma of group D. So the 3 and 5 year overall survival made up 97%, and the 3 and 5 year disease-free survival we've observed on the rate of 96%, and survival rates didn't vary in patients with different tumor stages. So I'll speak about the treatment modalities. The first one, the most frequent treatment modality we use in our routine practice is laser thermotherapy. So laser thermotherapy was performed in 251 patients, and the number of treated tumors in only eye varied from 1 to 48. Mean was 6, and the mean follow-up was 68 months to observe these patients. So conventional thermotherapy was performed for small single or multiple posterior tumors. So you can see the results of their work of the thermotherapy here. Firstly, you see the small lesions on the fundus, and then when you treat, they become more white, and then you can observe a flat scar on the fundus, and that is the sign of complete tumor regression. So small tumors, residual or relapsed, multiple tumors, residual and or relapsed also after the chemotherapy can be treated in different parts of the fundus, and it's very effective. So we also use thermotherapy as a primary treatment for small tumors. Usually it's group A, and we use it primary before the chemotherapy. If, for example, we have bilateral retinoblastoma, so you can firstly treat the best eye and then go to the chemo and treat the poorest eye. So we also use transpupillary thermotherapy with scleral depression for peripheral tumors, and we use it like transpupillar, and we also use transscleral thermotherapy. So transscleral thermotherapy was fulfilled without any conjunctional incision using scleral depression by the laser probe. So for chemo, and so there are some more pictures of the transscleral thermotherapy, I'm sorry, for the peripheral tumors. So for chemo and radio-resistant tumors of cavitary retinoblastoma that is too large for conventional thermotherapy and can be the reason for tumor growth, we sometimes observe these cases. So we use a step-by-step approach in which laser spots were applied only to the periphery of the tumor during the first treatment session, and on the next slide, you can see the model of how we do perform this. During the repeated session, laser spots were applied to the areas of hyperpigmentation after previous session in order to increase the heating of the minimally pigmented tumor and to increase the efficacy of the thermotherapy, which was especially important in eyes with minimally pigmented fundus. And this treatment modality is also very important in the single eye because, for example, this lesion you can treat with the chemo, or you can treat it with the plaque, but it's very near to the center, and there is a very high level of the complications that you can receive here. So you can see the lesion on the fundus here after the first session, then after the second, after the third. You can see the very, very pigmented area around the tumor. And after 5 sessions, so we've seen stabilization, and so the tumor was seen to be completely gone. So in order to determine the most important clinical and treatment variables of thermotherapy efficacy, we have performed multivariate analysis of clinical and treatment variables of thermotherapy success. So the major reliable predictors for chemotherapy success were tumor size. It was thickness less than 0.7 millimeters. Largest basal diameter less than 1.5 millimeters, fundus pigmentation degree also, post and pre-quateral location, and small number of treatment sessions. So the second type of local treatment I'd like to speak is brachytherapy. And this treatment modality was performed in 274 patients with different group of retinoblastoma, and there were 45 patients with a single eye, and also there was pre-treatment in every single case. So it is known that brachytherapy has a geographical affiliation, and there is no ruthenium and strontium plaques in America, as there is no iodine plaques in Russia. We don't work with them. So, and we use in our country, we use ruthenium and strontium plaques, and strontium plaques are used in Russia only. So it is known that the difficulty of the brachytherapy include correct plaque position that can be a reason of incomplete radiation. So for this reason, we precise tumor projection on the sclera was determined by simultaneous ophthalmoscopy with scleral depression and transillumination. Scleral depression was performed by curved light pipe that you can see on the fundus by a light. So the total of the scleral depression was marked by a blue ink and repeated transillumination, and you can see the blue dot on the eye. So it helps a surgeon to put the plaque correctly. So in order to decrease the irradiation zone, we also, for small tumors only, we use a specially designed radio impermeable silver collimator. So, and we usually use this for the tumors up to 3 millimeters in basal diameter and 1 millimeter in thickness. So here you can see the work of plaque collimator. There is very small tumor on the fundus, and we fix it on the eye with the use of light, and here you can see the result of the plaque work. So the tumor has completely gone. So we usually use brachytherapy as a first line of treatment, and also we use also as either ruthenium after intravenous chemotherapy. You can see on the slide here a recurrent tumor, very big tumor on the skull. So it was successfully treated with no tumor relapse seen within 12 months. So here is one more example of successful use brachytherapy with ruthenium. And also we use a strontium, as it was said in the previous speech, that but we use it for very small tumors up to 3 millimeters. And here you can see the example of excellent experience of the treatment, so such a tumor. So we also use strontium for juxtapapular tumors, and here is one more example of this work. So as you can see on the slide, there is no statistical difference between ruthenium and strontium plaques tumor control, but as you can see on the slide, there is a significant difference in complications. We usually see less complications in patients who underwent strontium plaque brachytherapy. So brachytherapy modes include irradiation of solitary tumor. We also perform brachytherapy of two large tumors at the same time. We do perform irradiation of multiple small tumors with low clearal doses. And we also perform irradiation of vitreous parietal seeds. When you have the single seed, not to perform intravitreal chemo, you can irradiate such seed with a flat scar that you can see on the slide. So we also use different treatment modalities in cases of brachytherapy, and also use multi-field irradiation. We use 2-field irradiation, 3-field irradiation at the same time, and even 4 fields of irradiation, and even 5 fields of irradiation when you move the plaque on the eye, and irradiate different parts of the eye fundus. So we also use plaque transposition when you have tumor lesions in different zones, and we also use 2 plaques fixed simultaneously when you have the lesions on the different parts of the eye fundus. So as you can see, tumor control was equally achieved in single field and multi-field irradiation types. Eye retention rate was also equal, but but brachytherapy complications were seen in 34 cases, and included proliferative retinopathy, non-proliferative retinopathy, and cataract and vitreous hemorrhage also. So among risk factors for complications, the following were identified, and among them there were tumor thickness more than 2.5 millimeters in thickness, and tumor diameter more than 7.3 millimeters. There were also risk factors such as scleral dose more than 626 gray, and the posterior location that you can see on the slide. So we also counted the time from intraarterial chemotherapy to brachytherapy, and it was demonstrated that it is better to perform brachytherapy 3 months after in eyes treated with intraarterial chemotherapy. So, and also the number of complications depends on the type of plaque, because the bigger plaque you have, the more complications you should observe. So there is no video, sorry, it's, I don't know why, but cryotherapy, as it was said, we perform in standard manner, and with cryo, we treated 90 patients and 104 eyes. So in some cases, we do perform single fraction radiosurgery as an eye salvage treatment of children with resistant or recurrent intraocular retinoblastoma. And we use also as either gamma knife radiosurgery, or cyber knife radiosurgery. So external beam radiotherapy is now not used because of severe complications that are observed. So the first complication is mid-facial hypoplasia, and the second most severe complication is secondary cancers that you can observe in patients in the regions of irradiated areas. So nowadays, there are external irradiation techniques for retinoblastoma, including proton beam radiotherapy, intensity modulated radiotherapy, and stereotactic radiotherapy also. So in our center, there were 20 patients treated with this treatment modality, and also all these patients were treated because of chemo-resistant retinoblastoma, because of tumor progression, artery spasm, or insult during the intraarterial chemotherapy. And in all these cases, parents rejected enucleation. So during the preparation for the procedure is also always performed under the general anesthesia. We do perform 4 extraocular muscles, and then after that we perform stereotactic frame fixation. So now we have 3 types of planning. So there is retinal tumors that can be radiated. There are vitreal tumors that also can be radiated, and there is the third type of planning when you irradiate retinal and vitreal tumors. So after the planning, the procedure is performed. And here I will show you some cases. So the first boy was treated because of resistant retinoblastoma. This retinoblastoma was treated by intravitreous chemotherapy. And here you can see the planning and the results of the radiation. So, and on the planning, you can see that all the vitreous was put in the PTV, in the planning target volume. So, the tumor was completely gone. The next case of the vitreous radiation is presented here. So, this vitreous seeding has completely gone within 32 months after the treatment. So, and we also observe this patient still. The next case is presented here. It's the girl of monolateral retinoblastoma. She had an insult during the intraarterial chemotherapy. Parents refused enucleation, so there was a tumor relapse on the calcium and in the inferior region, if you can see. So we performed the irradiation with excluding critical structures, and as you can see, within 5 months after the gamma knife radiosurgery, the tumor was completely gone. So one more example of the cyberknife radiosurgery in the child of monolateral retinoblastoma group D. There was also performed chemotherapy, but the progression at the optic nerve head was seen, and patients also rejected enucleation, so the cyberknife was performed with a complete tumor response. So the results of gamma knife and cyberknife are good, and among the eyes that could be enucleated, 75% of eyes are saved. So we do have complications. They usually have hemorrhagic character. We have cataract also, but these complications are curable, and we should mention it. So in conclusion, I'd like to say that local ophthalmological treatment is an essential part of retinoblastoma management, despite the high modern successful local and systemic chemo. Some novel approaches to local treatment can increase the rate of eye preservation in retinoblastoma patients. So, thank you.
Thank you so much, Dr. Vera Yarovaya. Thank you for telling about the local ophthalmic therapies and also the radiotherapy. When we think of the chronological history, so radiotherapy was used to preserve eyes, and now we want to avoid radiotherapy because of the late effects. In the ones that have the RB mutation, in the genetic ones, in the sites where of irradiation, the osteosarcoma is 200 times more. So it is very important, especially for the ones that are really hereditary retinoblastoma mutation. And now then we have gone to pre-enucleation chemotherapy era, and now we have the intraarterial chemotherapy to preserve eyes especially. And Dr. Vera has also said about the new radiotherapy techniques, but we should not forget that the proton therapy or cyber knife or gamma knife are also radiation. So they may have their late effects also, just to keep in mind. Dr. Guillermo Chantada, if you will also open your camera and we can go over some, there are many questions, and also some of the questions we can just put in some groups. I think the genetic counseling is important, and in low middle income country, usually we do not have many people that work the genetics. Sometimes we cannot even do the RB mutation timely. Sometimes we do it with some grants retrospectively, but it is very important. Dr. Guillermo Chantada has already mentioned that even in unilateral cases, 10 to 15% can be hereditary. So it is very important. Sometimes they come and say, we want to have another child. So is this unilateral? So is there a chance that we can? Yes, there is a chance. If you cannot look at the RB mutation, there is a chance. In fact, I want to tell you shortly, we had a case that came with bilateral retinoblastoma, and the grandma seemed to me sound familiar. And I said, well, oh, she said, yes, my son was your patient 20 years ago. So the uncle of that bilateral patient was a unilateral retinoblastoma who was treated, and the eye was saved, his life was saved. And at that time, we could not look at timely the retinoblastoma mutation. And the grandma's eye was enucleated, and we had asked her why, and she had said she had a trauma. And her mother was still alive. She was about 60 years of age. And we said, go back and please ask your mother, were you really had a trauma or was it different? And then after 60 years, she learned that she had her eye enucleated because of retinoblastoma. Because in low middle income countries, because of the stigmas, and the families do not want them to know that it is a cancer, if it is unilateral, it is enucleated, sometimes they will not tell the child. And we miss an opportunity. The other, we didn't know she had retinoblastoma. The uncle had unilateral retinoblastoma. And we said, well, if he is married and has a child, please tell us. And he said, he's married and has a child 15 days of age. And we just called them, and the child had bilateral retinoblastoma, one eye A and one eye B. Both eyes are saved, but it is very important to ask the family history and to know about the stigmas that we have in low middle income countries, because they will not tell that they had cancer to the child also. And that even in unilateral cases, we can have some hereditary cases also. We have a lot of questions for the chemotherapy. I think, Dr. Chantada, I would like to address that to you. For the chemotherapy, pre-enucleation chemotherapy, or the ones that have already enucleated and are A or B. In A and B, we will not have enucleation, but in the pre-enucleation, in the chemotherapy, usually the COG will use increasing carboplatin. In the intraocular C, D, E, they would suggest increasing carboplatin etoposide. And now you have, as you have mentioned, that etoposide can also cause some leukemias, especially AMLs, because of the chromosome 11. So what do you recommend? This was one of the questions. What kind of chemotherapy, which agents do you recommend in these patients for chemotherapy?
Yeah, that's a great question, Rejin. Please come to the next webinar in about 3 hours, and we will clearly show it has been completely proven that the risk of AML is higher in children with retinoblastoma. that receive chemotherapy either with etoposide or alkylating agents. So we don't use etoposide anymore for ocular preservation. We do use etoposide on the cases where the life is a danger, because you need to use all the agents you have in hand, because the child can die of retinoblastoma and the risk of dying of AML is much lower. But when you try to keep the eye, we don't use etoposide anymore. We use carboplatin and vincristine. And there was a very interesting comment by Michael highlighting that it's probable that if you add vincristine to carboplatin for small children, you may have more likelihood of ototoxicity. That's completely true, and also other toxicity, because sometimes these are more small children. So even carboplatin alone can be a good alternative. So that is, not many groups are doing that. Some are still using etoposide because, as you will see in the next webinar, the risk of AML is relatively low, but it's there. And some groups say, I have not seen a case, but you will not, because it's quite rare, but it's definitely rare and sometimes can be fatal.
So for the intraocular A and B, vincristine carboplatin is enough, but for the advanced C, D, E, in E usually we enucleate if it's unilateral, but if not, I mean, would you use only the two agents, or would you recommend to add another agent? I think that was specifically the question.
We don't use systemic chemotherapy for preserving group D eyes anymore. We use intraarterial chemotherapy. So I don't have that experience. If I had to give a recommendation, it depends. If it was the child, like in the 8-month child in the case, I will give etoposide, because the risk of blindness is very high. These children are quite likely to.
Practically in settings where you cannot give intraarterial chemotherapy, you can do so. Dr. Zehra, Fadoo, please. Yeah.
Thank you so much. It's a very interesting seminar, Dr. Chantada and Dr. Vera. That was very informative. Now, Dr. Chantada, my question to you is that, when like in low middle income country, as a follow-up on the genetic risks, we see unilateral disease in a child. And then my question is that when do you really label them unilateral? Because you don't know, a few months later on, they might go ahead and develop it the other eye. So is there a duration from one eye to the other eye that you can safely say that, after 2 years, if it doesn't develop, then unlikely is going to be. So is there something like, is there a continuity or a time lag between RB developing in one eye and then in the other eye? Because sometimes it's very difficult to label them unilateral exclusively, because if they come at an earlier age.
Yeah, that's a very good question. And there is a paper quite classic paper from the Dutch group. They are the ones that have lots of experience in a very complete registry. They have a great follow-up. They sent an update. They published an update last week, I think, and in ophthalmology. But I remember maybe it's around the age of 4, when the child has not developed any other tumor in the fellow eye at the age of 4, or around that time. I think they put like a very precise time in months, but it's around 8 years of age. The likelihood of seeing a contralateral tumor is very, very low. But that still doesn't mean that the child doesn't have a germline mutation, like the case from Rejin. You can have only unilateral and never develop a tumor in the other eye and have a germline mutation. And let me go back. We have only 3 minutes. Maybe Rejin wants to go to another question, because there was an extremely interesting thing in the cases presented that we didn't discuss. But I think there will be more questions.
Yeah, maybe if you want, if it's a burning issue, please do so. And
no, it was a nice, because you say, as far as I understood, there were 2 children with retinoblastoma coming from that were not twins, that came from healthy parents with healthy meaning not retinoblastoma patients. So one thing that should be done in these cases is a fundoscopy of the parents, because you might find a retinoma in one of them. I'm sure one of them has a low penetrance mutation. We don't know why the parents didn't have retinoblastoma. One of the parents didn't have, but at least you should look at the fundoscopy of the children, and there is also the possibility of the father not being the father that you think it is. So there may be someone else with the known retinoblastoma clinically that could be the father.
Dr. Chantada emphasized that something very important. So the ophthalmologist will also look for the parents, because in that family that I told
All
you,
the time.
one of the
Yeah.
mothers, the mother of that bilateral one, had retinoma. So she had gone
Yeah.
undetected. And
Yeah.
in our series, we have such cases. And Dr. Vera, in your series, you had about 30%, less than 30% with intraocular advanced stages, DNE. For example, in our cases that were just published in January 2025, 1983 to 297 patients, 403 eyes. We had almost 60%, 40% group E, 20% group D. I think it may be that because you had also a long span, but maybe because these were since 1983, it may be something longer. But the survival rate is 96%. The eye survival rate in the unilateral is 30%, in the bilateral, at least in 70%. Why one eye was preserved? Because this is very important to preserve at least one eye. I think this is important. For intraarterial chemotherapy, some asked about the chemotherapy. There are centers that use only one, sometimes two, sometimes three agents. Usually it is melphalan, topotecan, and carboplatinum, either together or one or two of them. The doses differ usually, but melphalan, according to age, 4 milligrams, 5 milligrams, 7.5 milligrams. Usually that is the what it costs. Topotecan 0.4 or 1 milligram. Depends. Sometimes there are ones that use even more. Because of the short time, I'm just going quickly about during the questions that I took notes of. Would you like to comment on that also in the interarterial? As I say, if you have the if there is a chance that you can do interarterial nowadays, it's much better than doing the systemic. But in cases where you cannot, still systemic chemotherapy does help a lot. Dr. Guillermo, Chantada, would you like to? And also there was a question of the cataracts. Radiotherapy can cause cataracts, right? Brachytherapy can cause cataracts. Usually they can be taken by the lens can be taken by ultrasound and a new lens can be replaced. But the ophthalmologist is very important. No retinoblastoma can be treated without the collaboration of the pediatric oncologist and the ocular oncologist. The ophthalmologist is very important. Dr. Chantada, would you like to comment for the interarterial or intravitreal?
Oh yeah, I think we are almost on time now.
Yeah.
I just put the link to the paper that we published from the Gallup. There you will find a good table with all the doses, all the treatments. We need to update the dose of intravitreal melphalan, intravitreal topotecan. So it depends on the age, depends on the ocular stage. So I think please check the link. It's available in SIOP Connect. So if you're a SIOP member, you can access a full text.
And in fact, we can send Dr. Sagir some of the publications. So maybe it can be put on SIOP Connect. We have this possibility for SIOP members so that they can reach these important publications. So at this point, 90 minutes has gone by. Thank you so much for this very excellent lectures, Dr. Guillermo Chantada. It was a pleasure and honor to have you here with us. Dr. Vera Yarovaya, thank you so much for your good presentation, and Sara for presenting your case. And I also would like to thank my co-moderator, Zehra, Fadoo, and Dr. Sagir Khan also for this very important DiSPLeN series. Dr. Zehra and Dr. Sagir.
Thank you so much for arranging this. It was very comprehensive and very informative.
Okay, so
Thank you.
thanking you all and thanking all the participants. If you want your certificate, please do the survey and then you'll have your certificate. Thank you so much, all of you.
Yeah.
Thank you.
Greetings from SIOP.
Bye-bye.
Bye-bye.
Bye-bye.